This is a map of Germany, and I live in the very southwestern part of Germany, very close to France, not quite in the center of Germany. That is what makes it sometimes difficult for me with traveling. But okay, I did my physio exam in 1995, and in 1999 I started my first CRAFTA course with Harry because I knew him already from Maitland courses. Then I did my certificate in 2004 and I did OMT, also with theme from CRAFTA from TMD. And since 2008, I'm also a CRAFTA teacher. The theme of this evening is what do we as a CRAFTA group think about TMD and how we implement this into practice. Our visions, our beliefs as a CRAFTA group. We are an open-minded group. We like to have input from other ideas, from other concepts. We think in a functional way. We do not only treat with passive movements. We always think in a functional way and try to do active movements with the patients. And we also think it's not only to treat the joint DMG, but we treat regions. And we do not only treat the craniomandibular region, but also all the regions that are connected with the craniomandibular region and maybe sometimes also are cause of the problems of the symptoms of the patient. We get our knowledge mostly from pediatrics. That means, how do we as humans grow? How do we develop? This gives us a lot of ideas and a lot of information, how we work, how things work, and how we have to create good function. We are interdisciplinary. We work with other groups. We work with lots of dentists. We work with speech therapists. We work with many other people of other groups. And it's always interesting if you join our Congress. Our Congress is always multidisciplinary, and it's very interesting to meet people from other groups and to have an idea and have the opportunity to discuss with them. And yes, we do cranial bone techniques, but we have a functional approach with it. And we integrate modern models of pain mechanisms. All we teach is based on evidence. We also believe that a therapist is not only a therapist, but also a coach. Well, what is TMD? According to the AAOP definitions, disorders of the masticary muscles, the temporomandibular joint, and its surrounding structures are affected. That means that several factors influence TMD. For example, persistent nociception from the affected region, but also contributing factors such as parafunction, stress, and maybe occlusion, poor occlusion. Examples for parafunctions is clenching, teeth grinding, nail biting, cheek sucking, anything you do that is not necessary for nutrition. Oh, sorry. The assessment and treatment of TMD with orofunction dysfunction are complex. The therapist takes a biopsychological or multifactorial approach. Follow the guidelines of DC-TMD model. That means there are axis 1 on the one side and there are axis 2 on the other side. Axis 1 means the physical symptoms and axis 2 means the psychological things. This model is evidence-based and can easily be integrated into the scientific praxis. Here you see the MOM model. This is an example of circular models. This might be a good model to explain to the patient where his pain comes from. because you can draw it and you can easily explain whether there is a damage in the tissue which causes the pain, or maybe it's in his brain, just the processing of the afferent information which causes the problems. Or, on the other hand, can also be output, for example, the clenched jaw muscles because of parafunction. But this model also has advantages, but it has also disadvantages. The advantage is it's easy to use it for the instruction of the patient, and it emphasizes the complex nature of pain so that the patient can see maybe it's not only the tissue, but maybe it's also, for example, my brain that causes the pain. The disadvantage of this model is that it has less focus on risk factors, less focus on contributing factors such as environment. And it focuses primarily on pain rather than functionality or disability. So there is a second model we can use, that is the biopsychological model. Biopsychological model means that there are three areas that potentially cause the pain or the symptoms of the patient. On the one hand, there's the biological thing, that is the neurotransmitters, the mediators, the synaptations. But there can also be psychological factors such as affective, cognitive, and pain experience. And third, maybe the social environments, the social factors contributed to the pain or cause the pain. That may be a relationship with friends, working situation, living situation, and these things. The advantages of this model is it is a comprehensive model. It considers multiple factors and it's more individualized. You can show better the individual factors to a patient. And it emphasizes psychological and emotional and social aspects. Although it has some disadvantages, that is, it's complex and it has no specific guidelines. And maybe with this model, you overemphasize the psychological factors. Here are some Here's some literature. We mainly base our our literature on. Now, how do we do with assessment? The therapist obtains an overview of the patient's individual problems, such as, for example, the location and the behavior of the symptoms, and also contributing factors. We as a therapist attempt to hypothesize and do clinical or think about clinical patterns. Here is a body chart we use in CRAFTA therapy, but we do not only use the body chart of the head and face, we also use it from the whole body. To draw the symptoms in the body chart is the first step, and we also draw the quality or write the qualities of the symptoms, and we write if it's deep or superficial, and we write if it's intermittent or constant. Then there's also interesting to see or to ask the patient if there's a relation between the different symptom areas, so that we can see if there is to be looked for one cause of the symptoms or more causes. And we also draw in the symptom-free areas. Also interesting is to ask how do the symptoms behave during the day or during the night. That means behavior through 24 hours. It might be interesting to think about the 5P factors because they say something about etiology of TMD. 5P means there may be presenting issues or presenting factors that are factors that are operating at the moment when the patient comes to our clinic. And there is precipitating factors that may be some specific event or trigger that was in the past and triggered the symptoms. And of course, we also have to think about perpetuating factors that are always things that maintain the problem, and predisposing factors, factors that put the person at risk of getting symptoms. That may be life events or asymmetry. And the very important and big factor is the protective factor. Maybe this is a person that is very positive in life and has his good social environment and is happy with life and with his work. So maybe this is a factor that protects this person or this patient from having severe problems. So that is also a positive factor. Here are some examples I wrote down for presenting factor, maybe a physical trauma, that may be a long-lasting session with the dentist. Precipitating factor, sinusitis, or dental treatment in the past that caused maybe damage on the nerve. As perpetuating factors, you must think about perfunction, of course. And predisposing is growth, is genetics. For example, if the patient doesn't have a class 1 occlusion, but a class 2 occlusion, which we all know causes more stress on the disc. And I already mentioned the protective factors. That is also sleep hygiene and the general happiness. I also listed here some questions you may ask or you might think about concerning these 5P factors. For pain, maybe you ask the type of pain. If the pain is nociceptive, the treatment will different from if the pain is neuropathic or central caused. Also, we ask for somatic or medical factors. Many patients that have suffered TMD also have comorbidities, such as headache or cervical pain, or also tinnitus, sinusitis, and so on. We also ask for cognitive factors, that is, how does the person or the patient perceive the pain? What does he think about it? And emotional factors, what does he feel about it? Is he angry about it? Is he depressive about it? And is behavior of the patient okay? Is he conscious of the problems or is he not conscious of the problem? Has he already adapted? Does he move in a different way, for example? And is his social life affected? Is he able to continue with his work? Is he able to continue with his hobbies and his sports and so on? And we always wish that the patient has motivation to improve, that the patient is willing to help to do his own job, to help to get better. It might be useful to use questionnaires which are standardized. Here are some examples you can use. That is Grady Chronic Pain Scale, Conti Amnestic Questionnaire, Facial Disability Index, or the Craniofacial Pain and Disability Inventory. There is, of course, a lot more of them, but these are some you can easily use in your clinic. Now, let's turn to physical assessment. The physical examination is multi-structural and it's intended to more information to what we already know from the subjective assessment, means from what we ask the patient. And we do tests that correspond to the latest scientific findings. And we do plan. We plan our physical assessment because we must make sure that we do not cause more problems with our physical assessment, and we want to have a good plan of what to do, of what we want to see, of what we want to test on that day. This is just an overview of what is maybe to do in the physical assessment, but of course not a list you have to tick off, because we do not do all this with each patient. This is just an overview, an idea. And if we start with inspection, we do posterior inspection, we do overall inspection. We also do inspection of the face. We look for asymmetry, we look for some hints, for example, predisposing factors, and we sometimes also do intraoral inspection. This is a patient of mine, a young girl, with a very interesting mouth opening. This is another one. And this would be the first thing to do if she has an asymmetric mouth opening, is try to correct her or give her an idea how to change it. Ask her if she can change it actively, if she can it do in a symmetrical way, because this already gives you a hint of where to start with the treatment, if that is an intra-articular problem or more an extra-articular problem. I think all of you who do manual therapy would do it like this. They would do the correction first when they see the active movement. What we do with the active movement, we observe it. We try to find if the mouth opening is symmetric, if there is an evasive movement of the head. I did not do the video with the head because of privacy, because I would have to blur the eyes again and all that. So I only did the video of the mouth in this case. Of course, we look if it's asymmetrical, and we try to find out and hear, listen if there are noises or not. And if she does movements of the cervical spine with the movement combined. We look for general hypermobility, and we look for control of the movements. Is she able to control the mouth opening, or is it poor control? And of course, we can do the palpation on the condyle and try to find out what the condyle is doing. Here you see how the movements of the jaw can be measured with a ruler, the mouth opening, the lateral protrusion, and the pro and retrusion in that case, because the movements have a relation. If you measure the opening and if you measure the lateral protrusion, they have a certain ratio. And if the ratio is okay, you know, or you have another hint that it's not an intra-articular problem. If the ratio is not okay, you have a further hint for the hypothesis that it's an intra-articular problem. On the photo below, you see isometric tests. We test the control of the jaw muscles. But we also have this genius test battery of motor control. This is 8 movements as a test battery. And if we do this in the first session, I often have a really good idea about the clinical pattern only from this test battery. And this test battery is quite valid. It says the test battery can be used to differentiate between subjects that have musculoskeletal impairments of the region and not. And there is another scientific science that says that there's a strong connection between the craniomandibular region and the craniocervical region. That if patients do have more dysfunction and more pain in the temporomandibular region, they also had more dysfunction and pain in the craniocervical region. This is always to take in your mind because we have regions that are connected with the craniomandibular regions, and it's worthwhile to look at them, to assess them. And this is something really specific of the CRAFTA concept because we take in mind all the 12 cranial nerves. We do assess them and we can also treat them. Here you see examples of tests of conductivity of the trigeminal nerve, and you see the neurodynamic test of the trigeminal nerve. But we can do this with all of them, with all the 12 ones. We also do differentiation tests in order to get sooner and better to the real source of the problems, to be faster in our assessment and in our treatment. We have different differentiation tests. We have some possibilities. You see the occlusion test on the first photo, kinesthetic sensibilization occlusional test, and you see a differentiation if there is a neural source or if the nerve has got to do with the problem. And on the right photo, you see a test battery again with a functional demo. The patient has his problems is with a movement. So you can differentiate there again also. Then noises is always a big question. Are the noises from the disc? Yes or no? Here are some ideas to look at, to check, to find that out. But of course, you always have to see it with all the other results together. Maybe I can. Oh, okay. There was someone else in the waiting room. We also do passive movements with the jaw or in the craniomandibular region. We do the physiologic movements and we do accessory movements. We do them as an assessment, as a test, but we also do them as treatment. And we also have some specific tests, specific differentiation in the jaw region and this dental stick test, which helps us again to find out whether there is an intra-articular problem or not, especially in the acute cases. And thanks to Mariano Rocabado, we also have this pain map. We can palpate the local structures around the jaw, around the joint. If there is a nociceptive problem, if there is an afferent problem, we can identify the structure that may be the cause of the problem. So, pain physiology, classification of pain, and trigeminal sensitivity, and if there is a peripheral or central sensitization, are important hypotheses we also try to build up and try to prove. And there are functional connections with other body regions, of course, especially with the cervical spine area and with the also connected to posture. We also have to think about and build hypotheses about contributing and risk factors because they maintain the problem and they have big influence on it, and we have to reduce them, or the patient has to reduce them. All this data is included in the planning, and we do planning for short term and we do planning for long-term management. As management strategies, we can divide into hands-on strategies and hands-off strategies. As hand-on strategies, there is, of course, mobilization of structures, of local structures, reduction of muscle tone, changing of the efferent input of the proprioceptive input, and of course, treatment of other relevant tissues that are all around in this area and in the connected areas. As hands-off strategies, there is a lot to do. First, of course, the information of the patient, the right and good information, that he knows what his problem is, that he knows what's going on, that he knows what he can do for it, and that he knows what we can do for it, how long it will last, and how he can help us or help to get better. Of course, pain education is a big, big theme. In the case that it's not so much an afferent problem, pain education is very important. And as I said at the beginning, exercises for autocontrol are important. The patient has to do his own job. Automobilization, stabilization, stretching, or just coordination exercises. He has to think about and get aware of his habits, of his posture, because maybe he has to change it. He has to retrain them, which takes a long time and needs much motivation to keep training it. And maybe he has to think about his environment, his social environment perhaps, and has to do some changes there. There's also good scientific evidence that aerobic exercise always help to reduce pain, to change certain processes in our brain. Also, there is good evidence for high impact exercises. And we try to retrain somatosensory integrity if that is distorted. We use mirror training, for example, for that. And we use emotion training for that. And motivation is very important. To give the patient a positive feeling that if he does his work, his homework, his home exercises, that he will improve. So we have short-term goals and we have long-term goals, which we have planned. And we give good support and consequent support to the patient to help him on his way, to guide him on his way to improve. And maybe this is a long-term support where we see the patient every 2 or 3 months. And we also have the possibility to give him an app to train with. And we have more digital opportunities. Management means continuous repetition and addition to continue working, to continue with all the exercises we have given. So, CRAFTA therapists treat according to training standards that come from other therapies, such as craniosacral, that differ from other therapies, such as craniosacral therapy and osteopathy, and alternative medicine. We are based on evidence. All we teach is based on evidence. We treat in consensus with qualified medical professionals, such as ENT doctors, speech therapists, orthodontists, dentists, and so on. We prefer active management and we do not do isolated passive techniques in this area on the joint. We work with our patients and we respect the necessary treatment and their wishes. We do it in an individual way. We do not treat according to a plan, because there is no plan for every patient. Every patient has his own plan. It's individual. Here you see a photo of treatment of hypermobility. Just an example. I don't have video, I just have photo. So, as a conclusion, the CRAFTA training adopts a refined approach, emphasizing the biopsychological model, which integrates contemporary insights from pain sciences. This method places a high priority on recognizing and treating the patient as an individual. The core of the training involves a comprehensive musculoskeletal example, an orofacial and cervical complex. Additionally, it includes a thorough evaluation of risk factors and other relevant aspects to devise both a short-term and a long-term management, and that plans the patient's specific needs and circumstances. And this is good and really latest news. Harry himself will do an update course for certified CRAFTA therapists, especially for them, in March, in May, and in October this year, once in the Netherlands, one in Hamburg, and one in Austria. You can see this on the CRAFTA website, and you get 40 accreditation points for it. And this is another latest news. There's a new course, also taught by Harry van Piekerts, about orofacial somatosensory distortion, assessment and treatment. There are two possibilities. One course is partly online, and one is only attendance. And you see what you can choose of. This is a very latest scientific information, and very, very good if you have patients with chronic face pain, if you have patients with problems with the facial nerves, or with trigeminal nerve problems with face pain. And also look at our website to find other courses, and look at our websites for future webinars and for jam sessions. So now I've come to an end, and maybe you have questions. We collected the questions. We can answer the questions now.